Okay, and so I'm going to broadcast. And the participants will start going. I have just the captioner on my screen, which
any
okay.
Yes. On your screen, you don't have your full name, Hug.
Okay.
Yet.
Yep. Okay. So we are now, if we can, if you remember to mute yourselves until you're speaking, and then unmute again. And our participants are now joining. I'm just going to start welcoming everybody to this online webinar, where we'll be looking at the ethics of research in low-income settings in relation to COVID-19. We have three speakers who have offered to give their time to us today. Gustavo Matta from Brazil. I have Gagandeep, Kang, and Aissatou Touré. I think that you can see on the invitation the details, so I won't go through lengthy introductions. I just want to say to those who are attending, who are still arriving, so we'll just start in a minute. Just thank you all for joining us. We're close to 100 so far and still rising. I should say to those who are attending, you will not be visible on the screen during this, but hopefully you can hear well enough. We will collect questions as we go through the Q&A function. The chat function would be too difficult to manage, but if you have questions, you can write it in through the Q&A function, which you find at the bottom of your screen. We will see if we can gather up questions that we will put to our panelists towards the end. We have got captions running in English to assist those who may find it difficult to hear or to follow. So if you want to follow the captions, choose the more function at the bottom of your screen and choose show subtitles, and then you will see the captions on the screen. We will be recording this so that we can broadcast it on our website later. Hopefully that will go up even before the end of today. So I'm Hugh Whittall, Director of the Nuffield Council on Bioethics. Our job broadly is to look at ethical questions arising in the context of biological and medical research. We published a report earlier this year on research in global health emergencies, not realizing that a new coronavirus was just emerging and that COVID-19 was such an emergent issue. And of course, research in the context of COVID-19 is going to be a really important part of the response to that. But it's still the question of how research is conducted ethically in this really difficult and immediately problematic situation is an important question. And so our three speakers will address elements of that question as we, and they will each present for 5 to 8 minutes, and then we will have discussion after that. So do please prepare questions. We've had 1 or 2 other webinars such as this that have gone very well. We will have more in the series, so do keep in touch. And at the end of this webinar, we will invite you to answer a short poll with a few questions, including what else should we talk about next time around. So I'm going to hand over now directly to our three speakers, and starting with Gagandeep Kang from India, who will take over the full screen for her presentation. Thank you, Gagandeep.
Thank you very much, Hugh, for the introduction and for setting the stage. I think everybody recognizes what a difficult time this is and how much really needs to be done. I'm going to use my 5 minutes to look at where research should be done in low and middle income countries and then stratify the kinds of challenges by the location. So if you look at a disease like SARS-CoV-2 or COVID-19, the first and most important thing for low and middle income countries is defining the size of the problem, whom it affects, and what are the kinds of interventions that you should be thinking about doing. Because everything that is available to industrialized countries, countries that are better off than us, can be challenging to implement. So if you want to tailor interventions to the kinds of populations that we have, you need to know where you are working and the size of the problem that you're dealing with. If you look at who is most affected, if you look at the kinds of areas where people live, it's well recognized that population density is a key contributor to the spread of infections. And the people who live in the most densely populated parts of our countries are the ones who are going to find it most difficult to implement any of the suggestions that are being made for social distancing. They already have limitations that relate to what happens during a lockdown. If you live on daily wages, for example, then you have no food coming into your house. How do you deal with research in a setting where people are unemployed, going hungry, where they're being stigmatized for being places where there is disease? If you look at urban slum settlements, this is what is happening in our countries today. The disease is going to people that are unable to implement many of the interventions that we are being asked to do. Whether that is hand washing, how do you wash your hands when you have no access to water? How do you feed your families? How do you protect the elderly? The concept of shielding when you have 5 people who live in one room just cannot apply. And then to think about doing research in this setting, then I think it's very important that we think about what is the right way to do research when there are people that are as vulnerable as the populations that we are dealing with. It's difficult for researchers who are familiar with situations like this to think about, to talk to people who are administrators, to convince them of the need to do the kind of efforts that are required to be able to think about what kinds of interventions might work and how these need to be done. Because the last thing that an administrator wants is people coming in as they view it from outside to try and get data on what they are viewing as a population that is very, very badly affected. That's one area and speaks to the poorest and the most vulnerable amongst us. And then if you begin to look at the clinical setting, if you look at emergency rooms or hospitals, these are hospitals that are going to be way more stressed than anything we've seen in New York or London. They are hospitals that start from a lower level of availability of resources, of having personnel that don't have the same ability to be able to handle clinical care. And then if you think about doing research in this kind of setting, how do you create the structures to do this? We do have hospitals that have experience of doing clinical research in our settings, but then the prioritization becomes, today, what is my best contribution? Should I be functioning as a doctor or should I be functioning as a researcher? I recognize the value of research. I know that it needs to be done. I know that it will result in an intervention that will be valuable for the future. but is that the best use of my time today? So there are issues that relate to how researchers view themselves, in as much as there are issues that relate to the setting in which you want to do research. All the issues about getting informed consent in the context of an emergency, in an intensive care setting. How do you deal with these kinds of areas? And then finally, I'd just like to touch on the idea of interventions and the evaluation of interventions in the settings, whether community or in hospitals, where research needs to be done. Whether these are drugs or vaccines or distancing measures or separate ways of setting up isolation facilities, we need evidence. And to get that evidence, we need to have a structure in which research can be done. In our countries, trust in researchers, trust in the medical system is sometimes wanting, especially when you have both public facilities and private facilities. It becomes even more complicated, because the public health system is viewed as not being as competent as private care in some settings. And if you go to private facilities, the idea is this is an exploitative relationship where the doctor is looking to see what they can get out of me. So trust, anxiety, fear are all things that are operating at, need to be considered and are operating at a pretty high level. One additional point I'd just like to point out that may be a little bit different from what is being done in the West is the question of traditional systems of medicine and their evaluation. Whether it is traditional Chinese medicine or many things that are provided in Ayurveda or yoga or the multiple systems of medicine we have in India, one of the challenges for us is to think about clinical trials and balance how you view what is coming from a Western medicine concept and the traditional systems of medicine, to think about, if you have a limited number of patients, how do I prioritize what we should be doing? So I'll stop there and hand off back to Hugh.
Thank you very much indeed, Gagandeep. I think that I won't intervene here, but merely say that your last point gives us a very, very good link into the material that Gustavo will now talk about, which is the role of community engagement, and that where the questions about local practices are so very important. So I will invite immediately Gustavo.
Thank you very much, Hugh, and everyone. So just a second, I will share my screen. So this one. So can you see my screen?
I can see it. I hope everybody else can too.
Okay, thank you. So thank you again, Hugh and Nuffield Bioethics, so for the invitation. This is a very important discussion, and I also would like to thank to Professor Kang, because she introduced many important issues and questions to try to address. So first of all, I would like to celebrate the Labor Day, and today to celebrate our health professionals. So this is the International Labor Day in the entire world. So this is important to highlight this. So I would like to focus on three important keys. One of them is context. The second one is dialogue, and the third one is trust. So I would like to invite you to discuss with these values. So one point that I would like to discuss first is, so there's the interaction between community engagement and participation. So social participation is one of the pillars of the Brazilian National Health Services. social participation is inside the health system, and we have different equipments and tools to spread social participation, to build health policies and health discussion in local and in the federal government as well. So community participative strategies are crucial to respond to COVID-19 in the low-income, middle-income countries. So this is something that Dr. Kang also addressed. So, and we have opportunity to discuss a bit more about this. But participation means for us different domains. Participation means social, cultural, territorial, perspective, economic, and political. So it's not just about research and disease, but it's about the history of people, how people are living in many cultural characteristics that we have, for instance, inside in Brazil in different regions. So it's it's something to say that participation means polyphony and dialogue interaction, the recognition of the other. So we are diverse and multiple. So I also would like to relate something that Dr. Kang already said. So it's critical to say the division between research and health assistance during an epidemic response. We live this during Zika outbreak in Brazil. The semi-funding using to research was the same funding to support health access to many of the women and children with microcephaly in Brazil during Zika outbreak. And another point is it is also the same health professional, the same specialist, the same health institution are running at the same time research and health assistance. So it's very critical to discuss this, especially in low and middle-income countries. The lack of access to diagnosis and tests and supplies. This is also just an isolation to low and middle-income countries, but also to global health context. You can see this, where is Brazil in testing COVID internationally? We are testing very few, and how challenging is monitoring Zika and how to project response, adequate response to the entire country and especially to vulnerable populations. So this is very critical. It's not just about the capacity to produce tests, because Oswaldo Cruz Foundation has a capacity to produce in other Brazilian institutions, but we don't have condition to import supplies because there are many concentration in rich countries that are running tests massively. So this is something that we have to discuss ethically in the global health field. So the funding drop to science and technology in Brazil since 2016, was very critical because economic austerity is the characteristic of the current government. So unequal geographic distribution of scientific institutions and labs, and the lack of representative on race, gender, and social class among scientific leaders and institutions. So this is some issues that I would like to share with you to contextualize the relationship between science, health, and society. So one important issue that I think that Dr. Kang also mentioned. So this is very different conceptions and initiatives when we face COVID response. Social isolating impacts is different, are different in vulnerable populations. So we not talk about people living in the slums, for instance, but also indigenous people living in the streets, and also immigrants in our countries. Clinical trials have to involve adequate monitoring, health, and social assistance to participants' personal contacts. So this is something important. We will start to the research on solidarity, research on WHO initiatives, how we will deal with communication risk, how to involve participation families or personal contacts with this. So we would just focus on the participants affected seriously from COVID, or we will have a more broad perspective, especially in vulnerable territories. There remains another issues that I would like to highlight, the re-emerging of risk group category. This epidemic, it's a kind of narratives that we are re-emerging old categories that we thought that are missing since HIV epidemic in the 80s and 90s. So we are talking about risk groups. What are the risk groups? Elderly people, people with comorbidity. So we have a lot of these people all over the world. If we can think in epidemiological turning in our contexts. So this is to think stigmatization of individuals and social groups, and as well as the naturalization of predictable deaths. So, okay, they dead, but they are elderly, or they have hypertension, or diabetics, or they are poor people. So, some recommendation, and also I would like to have a very strong recommendation to read the Dakar workshop report that is in the very new report on health emergency from Nuffield, but I adapted a little bit and include some new recommendations. So recognition of the experience of people affected health emergency. So contribution to support a mutually respectful and dialogue partnership between researchers and communities. The two-way process contribution to design, conduct, and evaluation of the research. Transparency, contextualization, and well-funding trusts to recognize community characteristics and needs, social and health needs as well. Research planning has to predict, support, and analyze analyzes for social and economic needs, and establish community epidemic situation rooms. This is challenging when we have to work remotely, but we are starting to do this in Brazil, especially with people who live in these lands, in the favelas. So we're starting to organize situation rooms with researchers, health authorities, health professionals, and communities representatives. Not to just talk about research, but also to talk about how we are responding to social needs and health needs during COVID response. So, and just a second. And unfortunately, I have to share this terrible picture. This is a picture from mass graves in Manaus in current situation 2 days ago. And in March, our president said, it's just a little cold. I think that now that we are facing in some countries, this is the most important issue, how to coordinate response and how to deal and avoid political opportunity during these hard times to everyone. Thank you very much, and I hope we can discuss a bit more later. Hug, your microphone is mute. Yeah.
Got it. Sorry. Thank you very much, Gustavo Matta from Fiocruz. It's worth noting, I think, that speaking from from the UK, we should also recognize that there are communities who are more severely affected than others in the UK, and who are often fail to engage adequately with healthcare services as well. So we can learn also here about the kind of things that you develop in other parts of the world. I'm going to invite now Aissatou Touré, who is in Dakar, Vice Chair of the Senegalese National Ethics Committee for Health Research. Aissatou, if you unmute, you can go straight
Yes,
ahead.
I unmute and I say everybody hello and try to just start the sharing. Is it?
We have it, thank you.
You have it? So now I have perhaps to have it in, okay. So just, we have just trying to share with you the difficulties, the challenge and the attempting response in reviewing health research proposal during the time of COVID-19. And just to say that the first challenge, which is very not so easy to deal with, is the operational issues in the time of social distancing and urgency. There is so many projects that is coming at the same time that are all urgent, and there is a social distancing that lead the ethic committee to adapt the procedure and the way we are working. So now we are trying to send in time comments and observation of all members to the secretariats that are in charge of synthesizing in a consensus document. And after that to organize a Zoom meeting like this, and in order to discuss, amend and validate the different comments. So we, in the very short time, we have to multiply meetings to address the urgency, as the research could bring solution. But the issue there is that in general in Africa, not only for us, but that means that you need a strong, well-equipped and well-staffed secretariat to enable this efficiency in the work. We also need a committed member for reviewing protocol in sometimes very short time notice, and with sometimes very complex issues. Sometimes something has practical that a stable internet connection could be also a challenge, and also the availability of members, because we are not so many in the area and we are involved in different activities, sometimes in the direct management of the pandemics, sometimes in different other protocols. So it is very challenging to have the people here. And also some other practical question in our country for some very sensitive research. We monitor on the field how the proposals are implemented and does ethic value respected. But how can you monitor this when the research took place in isolation settings, facilities? So it is questions that we have to deal with, not answer, but we are trying to do our best. So for the second challenge that I want to share is the issue of dealing with sometimes new, sometimes not so new, but still complex issues. At this time, and it was the same during Ebola time, we have to deal with the assessment of scientific value of the projects when there are insufficient scientific evidence and social pressure to act. You don't have time to consult your other colleagues internationally or in the region. You have to deal sometimes with access to scientific or ethic journals, where several of them you need to have subscription. And at the time where you have to have accurate scientific information, you have to read what have been already reflected on the specific issue. And so sometimes in the most recent proposal, we have to deal with the issue of determination of what should be the reference treatment in clinical trials. What should be the control group at the time where chloroquine treatment in our country is currently used as part of the treatment by the clinicians, in addition to supportive care. And sometimes some protocol came and say, I want to really attest, try to see the efficacy of this molecule, but I need a control group with just supportive case, and it could be very socially challenging to just have this kind of control group, even if we know that it is a gold standard. So at one time also, and I think that my two other colleagues have already pointed at it, we have a problem with delimiting when ends the care and when starts the research. Sometimes it is the same people, and we can have issue with and deal with the issue of informed consent when you are addressing the research with quarantine person. The issue of unconscious person, we realize that we don't have legal tests to deal with that. We have sometimes a new way of doing research with distant consent by phone, for example, for social science research, which was not in our legal text that we have to adapt. So there is different kind of challenge that we deal with. But the third challenge that I want to deal is really how to get efficient and timely support. There is some existing and new or newly created networks, but I have to say that they are not yet very efficient, not very helpful at this moment. When you need a rapid answer, it is sometimes problematic. You have even sometimes limitation for registering. For example, I just go to the very new WHO network named FREFEL. That could be perhaps with time very helpful, but personally I cannot register because they say that you need, as I show you here, your email, you must be from an academic institution. Most of the ethics experts are not from an academic institution, and not even if they are in our countries, many of our servers are not very efficient and people use their personal addresses. So if you say that it was required, you will not be able to register. So perhaps what could be helpful for is really to have a community of available ethics colleagues that commit themselves to bring supports that are easily joinable for rapid exchange, and it's really something that could be helpful. I want also to finish with the other challenge of getting efficient time and support with the language barriers. Now I am talking to you in English, but I'm sure that I would be probably more convincing if I was using French. And the issue is that most of our experts, when there are no scientists, because in science you are forced to use English, but in other domains, you are not perhaps used to utilizing other language, and we need some help for translation of the training resources that can help you. And it could be very helpful if colleagues can really foster the translation in French, Portuguese, which are the two other languages with English used in Africa. Also, the other thing is that most of our ethics committee need funding for efficient functioning, but most of the funding now is competitive funding through international call. But even if I understand the issue of excellency, having to really take the most well-written proposal, but that means that those have with less skill will never get this funding. So if we don't change, the funding will always go to those who have already some level in these skills. I would like to finish with advocacy for funding already regional existing networks. For example, in ECOWAS, and excuse me for the typing error, for the 15 countries in ECOWAS, the National Ethics Committee have created a network, which is the WANEC. But still now, we are not able to start release our activity because we are still struggling to fund this activity and to have a very efficient secretariat. So at this time where there is this pandemic, we are doing our best, but sometimes it is really difficult because there is all this challenge that I wanted to share with you. And I will finish with that saying that we are really looking for how you can support for doing the work that is in front of us. Thank you, Hugh.
Many thanks, Aissatou. Now, I'm going to just move to, I still see your slides. Can I?
Yes, I can just, okay, how to.
So we will have about 10 minutes now to pick up some of the questions that have been coming through. I will show the whole panel now. So I'll just select a few of the questions here. The first one that came in was about multi-center, multi-country trials, and whether there are adequate systems available to ensure that local researchers can join as co-investigators and co-principal investigators at local sites where you have multi-center trials. Is that, does that remain a serious problem?
At least in our country, it used to be a problem, but by now, more and more, we saw that there is a local co-investigator, but sometimes it is on the paper. When you look inside and you look at the role of each other, often you see that the local investigator collects the information, but the data are not forcefully analyzed on site. It is abroad. You will have to deal with how the biological sample are to be shared. So, but we are very we look at this kind of issue and we try really to balance the interest of the research and the interest of the local researcher and of the country. We are, as a committee, even if the researcher don't have the strength to really have a better, fair contribution at our level, we can ask sometimes to better distribute the roles.
There's another question that I think is quite an interesting one, and maybe I'm not sure which of you may wish to answer this, but it was a question about in some circumstances, especially, for example, where in the case of migrants or people in very difficult living circumstances, actually participating in research can constitute a risk to them, a social risk to engage in that. Is that something that one can really manage?
So this is something that we have considered very carefully, and because they are migrant workers who are not accepted by local populations, they can be stigmatized, they can be excluded from society. So the questions that you want to research actually need to be relevant to that specific population. It should not be something that is for the population as a whole. It should be for that subset, for it to be something that would be acceptable to our ethics committees. It is challenging to do for both researchers as well as for the community, and you have to calibrate what you do very, very carefully.
Yes, just adding something about this. So it's also important during a pandemic that health surveillances and epidemiological studies are very hard. So I think that some issues about vulnerable populations and privacy can can put these people in difficult situations, especially in violent areas, especially when you talk about domestic violences. So I think we have to take care about this. And in the times of pandemic, it's very hard because there is a kind of sense that it's more important to protect the collective than individual people or some groups. So I think that is a very important ethical issues to be discussed.
Can I just put one more question, which each of you might wish to answer briefly, please, as we run out of time. But this is about, I think we've all recognized that the pressure on health systems and the pressure on health professionals is very intense, both in terms of existing lack of resources, but also with a redirection of resources towards the response to COVID-19, but with health professionals also then being asked to direct some of their attention to research. Is this, how do we kind of balance those priorities when actually it becomes difficult to do anything properly?
Well, I think that, I'm sorry, I think that it's important to organize this in different contexts. I think that in the context of the pandemic, every country has suffering the impact of it. Many of us are working all the time, even us that we are working remotely. We are facing different situations. So, and this is very different. But I think that how to strengthening to the next pandemic and during this pandemic, a very good supportive initiative for health workers who are running research at the same time. So I think that we could analyze this in a dialogue process between them and also involve it ethical committee to discuss ethical constraints on it, personal and institutional constraints. But also talking about funders, we have to preview it. We have to talk with funders how to deal and how to manage during a pandemic or important outbreaks all over the world.
Thank you. So Gagandeep, Aissatou, do you have one more brief word you want to add? And then I'm going to invite our people attending to complete a short poll. I'm going to put the poll up in a moment, but Gagandeep, Aissatou, one more brief word?
A brief word is that sometimes we are lacking of scientific evidence. And in Ebola, what was very helpful is this kind of international expert group, scientific expert group that prioritize the different existing candidates. And it was very helpful for the ethical committee to rely on this expertise because there was a very high level expert. But for this current pandemic, I didn't see how to deal with this issue of prioritizing the treatment of the candidates because there is not such international expert group to help in this issue.
Thank you.
So I had one note of good news, which was at least at our medical school, what we decided to do was to prioritize what we would see as important for the institution. And we decided that there would be a team that would look at certain kinds of studies. and would be available to do that. So that is how we are looking at handling competing clinical and research requirements. We had time to prepare, and I hope that time will show that we use that time wisely where research was concerned. The not so good part is in the context of the pandemic, everything is a problem when it comes to getting permission. So the ethics committee is all right, but if you want to engage internationally, there are huge issues in terms of getting permissions at the national level to be able to get that research done, even if funders want to support you. So I will end with that.
Thank you so much. So you will have seen that the poll is now up, and I see that people are responding to that. Thank you so much. I would just like to thank hugely Gustavo, Gagandeep, and Aissatou for joining us. I think that's opened up a lot of questions, and some of these things remain questions and they remain problems, but we should all together keep working at it. Once again, thank you very much. I'm going to leave the poll open for another minute or two so that we can gather up those responses, including your suggestions for what we should do in the next of our series. Once again, thank you all. Thank you for joining us.
Thank you.
Stay safe and well.
Thank you everyone.
Thank you.
Thank you, Hug and Nuffield. Thank you. Bye everyone.
Bye.
Take care.
Bye.
Take care.
Okay. I think that's it now, Aissatou. We're the last in. I'm going to close the meeting.
Okay. I forgot.
I'm sorry, we didn't answer all questions. I apologize if your question didn't get answered.
No. For me, I really thank you for organizing this. And I am sure that it would be interesting to look at the questions. And one of my questions is, even if we don't have time to go through all the questions that was written, is it a way to capture them and having the opportunity to answer?
We will include a summary of those on our website when we publish the video of this meeting.
Okay.
And
okay.
that's all. I think we have all of our responses. See you again.
See you.